All right. Welcome everyone to our webinar this evening. Um, just a quick plug for our international meeting in July and more information on the website. Really appreciate everyone logging on tonight and thanks so much for joining. My name is Sagar Kansara. I am a head and neck surgeon at LSU Health New Orleans. I'm joined by my co-moderator, Dr. Kevin Contrera, who is a head and neck surgeon at the University of Pittsburgh. And we have an all-star panel today here to discuss how to integrate circulating tumor DNA into a head and neck cancer practice. First, we'll start with Dr. Nancy Lee. She's a radiation oncologist at Memorial Sloan Kettering, where she is the vice chair of experimental therapeutics. She also serves as the head and neck service chief. She's a prolific author, clinical trialist, as well as an expert in de-escalation of therapy for HPV positive or pharyngeal cancer. We're also joined by Dr. Glenn Hanna. He is a medical oncologist at Dana-Farber. He is the director of the Center for Cancer Therapeutic Innovation. His clinical and translational research efforts focus on precision medicine approaches for head and neck cancer, especially in regards to molecular and immunologic biomarker discovery. And he's published extensively in this domain. And then we're also joined by Dr. Daniel Faden, who is a head and neck surgical oncologist at Harvard. He's a translational scientist as well. He's focused on leveraging molecular diagnostics to develop and apply liquid biopsy techniques. And his team has recently pioneered HPV whole genome sequencing assays, termed DeepSeq, to enable earlier diagnosis and with hopes of advancing early detection of this disease. So we very much look forward to the panelist discussion. If anyone has any questions for the panelists at any time, you can feel free to drop them in the chat, and after each segment, we'll try to address maybe two or three of those questions after each speaker has presented their portion. And so now I'll turn it over to Dr. Contrera for just a brief intro.
Kevin, you're muted.
Classic. Thank you. It wouldn't be a webinar if someone didn't forget to unmute. But I was saying, thank you, Sagar, and thank you so much to the panelists, and thank you so much for all of you who have joined today. We're telling ourselves we set the record with over 600 people who have registered, and I think it's a real testament to the interest that the field has in this area. And so, I don't want to take too much of your time because we're here to see our panelists, but I just want to give a very brief background of circulating tumor DNA as it applies to head and neck cancer. And so I do have some grant support, relevant to this field, but it's research support, no direct support here. So apologies for the AI slop, but I just kind of wanted to illustrate, the different options that we have for circulating tumor DNA. Of course, the most tried and true and traditional is blood or plasma. That's what most of the assays we'll be talking about today, but there are others, particularly drain fluid, and relevant to our field, oral saliva, although that's kind of the earliest. And there are others, such as urine for other fields, but not necessarily as relevant to head and neck. The real approach that is to be understood is how to actually apply ctDNA. And there's really three different ways in which you can apply circulating tumor DNA, and it all is relevant to how it relates to the treatment. So if you're looking to identify cancer prior to treatment, we would consider that cancer detection. There are certain assays on the market that are, pan-cancer screens. But most commonly, when we're talking about circulating tumor DNA, certainly where we have the most data now is for surveillance. So after treatment, can you detect a recurrence sooner in a patient? And I think, really an area of growing research and investment is through response adapted therapy. So can you use ctDNA to assess a patient's response, a patient's treatment and treatment response, and then adapt that therapy accordingly. And so, really, our this work really dates back close to about 10 years, where most of the earliest work was on viral head and neck tumors, both HPV and EBV. And I think we all kind of know where we were when this paper from Bishop Chera came out in JCO. And obviously, we all know it's kind of been adapted to some extent due to, enrollment related issues, but, it still is a real obvious step forward for our field. Since that time, we've really come a long way to beyond just tumor naive assays into more tumor informed assays, which are mostly necessary for HPV negative cancer. And this is a meta analysis we recently published looking at HPV negative head and neck cancer. And it demonstrates that for patients who had detectable circulating tumor DNA after treatment, the risk of death was tenfold higher. And it's pretty rare in head and neck cancer that you're seeing hazard ratios of 10. And so, this is really an obvious demonstration of potential. But really, where the questions lie is how can we integrate into practice changes or actually make changes in the way that we're treating patients to improve outcomes. And so, we have to kind of use circulating tumor DNA with the changes that are on the horizon, such as with neoadjuvant immunotherapy, where we don't have good biomarkers because there aren't really major radiographic changes. And so this is one patient from my K in which we're using neoadjuvant immunotherapy and then using circulating tumor DNA to assess response over time. But beyond just neoadjuvant, we can use circulating tumor DNA for adjuvant therapy. And so this came from a recent paper led by Jose Zavallos, in which drain fluid-based circulating tumor DNA is used to stratify HPV negative head and neck cancer. And you can see a real separation of the curves. And so this is the typical storyline. You see, really impressive prospective observational data, but it's on all of us as scientists to be able to use this in the clinical trial setting to be able to make informed decisions on how to change management. And so, for example, this is one such trial that we are building in which we're using drain fluid in the adjuvant setting to make adjuvant therapy decisions. And so our panelists today are going to be talking a lot of the leaps that they have been making individually for the field and where the field stands. And so I'll hand it off to them. And thanks so much again for all of you for being here.
So I will start and thank you so much for having me. And thank you, Dr. Conchera, for giving us the background. My job is to talk about how to integrate ctDNA into our daily clinical practice. And these are my disclosures. So I just want to think about two broad categories. One of those are virally related. I'm going to focus on EBV-driven nasopharyngeal cancer, a little on the HPV oropharyngeal cancer, as our other speakers will be focusing on that, and of course, on the non-viral related tumors. Nasopharyngeal cancer, why do I talk about this in a head and neck surgeon audience? Because we know that it's really a chemoradiation disease, but if you were to think about liquid biopsy, the absolute godfather of all liquid biopsy across all disease is this doctor named Dennis Lo in Hong Kong. In 1999, he published his data looking at plasma EBV DNA for nasopharyngeal cancer patient. He used PCR technique looking at enriching the fragment BAMH1 of the nasopharyngeal cancer genome, and then enrich this in a PCR technique. And then when it's detectable in the plasma, you have nasopharyngeal cancer versus the control. And of course, you can have false positives, but in general, this test is look at the order of magnitude copies per ml. We don't see this in HPV as much, but in nasopharyngeal cancer is very high, make it a very valuable biomarker. And the work is not just in the lab. Since 1999, they perfected and they conducted a study as a screening test for those patients that are at risk for developing nasopharyngeal cancer. This was published in New England Journal in 2017. Look at it, it's almost a decade ago, where plasma EBV DNA testing in asymptomatic at-risk individual. Who are those? The Chinese population that eat salted fish with genetic predisposition. And then they drew 2 time point of blood, 20 ml of blood by means of real-time PCR assay, again using their assay BAM-H1 fragment of the EBV genome. And then really remarkable work that they found patients, these are asymptomatic, remember, they were just on screening tests and they identified cancer by screening, had a better progression-free survival versus their historical control. They found the tumor at an earlier stage. And we all know when you find tumor in an earlier stage, you do better. And here's an example. You would not think about scoping a patient, but here, because it's positive blood test, you scope the patient and found it on MRI and treat accordingly. Patient just needs RT alone versus chemo radiation. So there's implication of less side effect as well. But remember, the assay is important. This is something you can implement in the clinic, but unfortunately, in the United States, we have to credential the test against NCI standard. I know Stanford did, and so did we. So we actually can screen test. And if you have a population patient, you're near Chinatown, you want to implement this, credential your assay against the NCI standard, and then you can do a screening test. And then why is that important? Because Quinn Lee has shown this in this paper back in 2013, because it's so sensitive, these PCR techniques so sensitive, you're dependent on your calibrator, your PCR mix, that, in a given tube of blood, depending on the lab you go to, you can have different result. And here, these are all expert labs, whether Taiwan, Hong Kong, Stanford. And look at pre-harmonization, the values all over the place. And then they found that it's the PCR master mix or calibrator, even the pipetting of the blood, that it really showed that you need to harmonize all parts of the assay or testing of the assay to get to a very close correlation. And even now it's 0.99. And this is important because if you're going to bring a test to the clinic, you better make sure that wherever this test is being tested, no matter what lab or what hospital, you get the same result. Otherwise, your study is going to fail. And that's just important for screening. Now, we know EBV DNA, there's so much literature. You pull it up, there are like hundreds of paper on this, and we can suffice to say, as Dr. Contreras said, this is a way you can use it to monitor your outcome. If you finish your chemo radiation, for example, for your nasopharyngeal cancer, and you have a positive test after treatment, you are a higher risk of survival of death versus if you have a negative test. And this has been done in meta-analysis. And we took this test and we designed this nasopharyngeal cancer where we use this biomarker, not just a greatest biomarker, but an integral biomarker. We're actually making a treatment decision. Patients with stage 2 or stage 3 and 4 tumor undergo chemo radiation or nasopharyngeal cancer. If your tubal plug was positive and then became negative, undetectable, one tube, you're randomized in a non-inferiority design against observation, which is not standard, versus continuation of chemotherapy. And this is important because we know that in multiple meta-analysis, we need more cycles of chemotherapy to cure nasopharyngeal cancer than just chemoradiation alone. And that's shown in multiple meta-analysis. But we also know the toxicity these patients have. I mean, after you go through 7 weeks of chemoradiation, they're pretty beaten up. And you have to give another 3 cycles of adjuvant chemotherapy. It's very hard. So this study is trying to say, can we select a group of patients that clear their EBV DNA and we can observe them, then give you the standard of chemotherapy. And if you have, unfortunately, detectable disease, it's about 22% to 25%, then we're switching to two different chemotherapy because maybe cisplatin, you're resistant during the concurrent phase. So why don't we change to gemcitabine paclitaxel? I'm very happy to report this was bang on my existence. Running this trial took forever. We're going to report the study out in July, and this may in fact change the standard care. And I really like this because I think we're over treating nasopharyngeal cancer. We need to be smarter in how to deliver chemoradiation. And then the story from nasopharyngeal cancer tells another thing. Now, when we look at the blood after treatment, if you just do one time point, that was the energy study because that's all the money we had. But this study from Hong Kong shows that if you're positive first and then you became negative, so it's two time points, you're positive post-treatment, then negative, your progression-free survival or your disease control is the same as if you're negative the first time point. So it tells you that there's a connected component, there's clearance that we need to learn. And it makes sense, right? I mean, just because we finish chemoradiation today doesn't mean the effect of chemoradiation doesn't continue. So you're really looking for the clearance of ctDNA, right? So that's something that we can learn from nasopharyngeal and draw to our HPV world. And I love this. Now we're going into there's a lot of study upcoming looking at quantitatively. Maybe after cycle chemo, you drop and look at this, you're an early responder. These patients should be de-escalated. How about after chemoradiation, after induction, you still have persistent plasma EBDNA, you do very poorly. These people should maybe get immunotherapy early. There should be escalation therapy. So this is coming the quantitative aspect, and I think that's what we need to do also in our HPV world. Now, two speakers will talk about more as well. So that's the nasopharyngeal story, and I'm going to shift quickly to oropharyngeal cancer, the more common disease. I like this review article because it's a one thing. Integration, I mean, multiple things, but integration to routine clinical practice is challenging due to the variation in their sensitivity and specificity. There's so many different tests, so different lab, some clear, some not clear, and then you have to look at it, and it's really hard. That is why Dr. Contreras said we need clinical trials. We can't just like, oh, it's cleared, therefore I don't want to do anything anymore. We have to really pay attention, do things on prospective trial to really find out who are the people that we can omit therapy, for example, after robotic surgery. And then we did the study. I really, really wanted to not give any adjuvant therapy after robotic surgery. We thought the TTMV assay was great. We said, all right, if you're positive and you did your surgery, you need to radiate, but you have two time points that are negative after robotic surgery. Can we follow the prostate paradigm, which is if you're negative, keep observing. In the prostate world, if your PSA is rising after prostatectomy, that's when you intervene with external beam radiation. So can we use ctDNA to guide us when it's rising? We will then give radiation. So it's delayed radiation. That's not an event. Then we had a stopping rule. If there's gross recurrence, we have to stop. And unfortunately, this study did show that 25% of our cohort after patient 12, we had gross recurrence, so we had to stop early. We published paper in Red Journal. Here's an example of a patient, pre-treatment 1608, pretty high TTMV DNA level. And then by 6 months, the assay is still negative, but there is gross disease. So it talks about sensitivity. So at least we can say that we cannot use this test alone to omit radiation, right? And single test omit radiation. I have wanted to do that, I can't. And then Luke Morris and Max Dean, and I call Max Dean the modern godfather of liquid biopsy at Stanford, did a lot of whole genome work. And here you can see in gross disease detection, depending, I mean, it can be very different. So we had to pay attention. And there's something about the sensitivity issue. We need to be more sensitive because if you want to omit any adjuvant therapy after surgery, you better make sure your test is sensitive enough to pick up any level of the DNA in the HPV DNA in the blood. And then here we kind of came to a conclusion that the study, the biomarker alone lacks sufficient sensitivity to replace imaging or tissue biopsy. We need to still prove that there is disease and very difficult to detect clinical occult disease when the disease burden is very low, like in MRD state. And we need to have trial. More important, I do think this assay is very helpful. You know how when we give chemo radiation, there's that stubborn lymph node, it doesn't go away. You don't know what to do. Should we do neck dissection? Should we not? PET is like equivocal. This is where you use the test to help you, to give you that extra level assurance. You can observe and maybe go to the next time point and maybe everything resolved and you by that point person not to have a neck dissection along with its associated toxicity. So I think this is where this assay is very helpful. And then this paper just came out. That was brought to my attention by Dr. Diplas, Alan Ho, and Zach Sumstead from the California Head and Neck Consortium. And their conclusion consensus, it's valuable for diagnosis, surveillance setting, but it is not for screening or treatment modification clinical practice. And then we need to validate, we need to do trials. So I think we're all speaking the same thing. We need to do trials. And then, of course, Glenn and Dan and I wrote this and basically said that it's still valuable, but maybe ctDNA cannot be used as a standalone decision-making tool to omit therapy. Maybe we have to combine with some other factor, and then we can potentially design our trials that way. But I did want to bring out, we didn't give up as a team, even though Linda Chan's trial was negative. Ash is carrying on the study where we had a cohort. You go to robotic surgery, you have positive margin, no one wants that. You have ECE, unexpected. Instead of giving 66 gray in chemotherapy, that is so toxic, triple modality, we de-escalate to 30 gray chemo radiation. So far, data is looking great using the TTMV assay and we only have one patient to accrue, and then we'll close the study. That's what's currently standard. Now, can we improve this TTDNA test? So this is work by Bill Diblas and Nadine Riaz, and papers going to be published soon. I hope it's under revision. A personalized cancer monitoring where you look at tumor sequencing, tumor informed, and HPV together. And what I want to show you is that when you have both combined, your sensitivity goes up much higher than either alone. So that is where the field is going into. And I think Dan's work on whole genome sequencing will talk about more on that. And then, of course, I wanted to talk about another assay, the signatory assay, which we started to also start to use where the strength is really is highly specific, it tracks the patient's tumor, it's strong prognostic signal, but there's some limitation because you need to have tumor tissue. But the good thing is if you're doing robotic surgery or surgery, you're going to have tissue. You just can't do it on finding aspirate. And then there's whole genome sequencing coming, so this is very exciting. And Glenn, I think, is going to talk about his work. Look at the difference. I just love the curve, the huge separation. And we need to do prospective trial based on their work and others. And also, I think there is bladder work already published using this assay. So more to come. I want to end by two trials. Energy oncology is going to incorporate ctDNA as a means to de-escalate. If you clear your ctDNA, you're going to be randomized to 60 gray versus 70 gray. Remember, head neck 005, when we just decided to drop by 10 gray, it was negative. So perhaps this is where ctDNA can help. Jillian Tsai and Sue Yum are developing this protocol. And then lastly, I want to end is that we at Sloan, we thought about, we want to continue our robotic program. Michael Wu and Rebecca Kell are two head neck robotic surgeons along with others. And Ash Shamsuddin, our radonc, and Winston Wang, medonc, we're going to have a trial coming where we're going to take anyone who has surgery, and then we're going to have this kind of flow chart. And then what's really sexy, I think, about this is the cohort B, this intermediate risk, you need to get radiation. Instead of giving 50, which is what ECOG 3311 does, or 60, how about 30 gray alone? And we need to do this on a trial basis. And so my plea for the surgeon is I know we do robotic surgery, and I think robotic is great for patient, but please do not just decide to not give radiation, think, oh, I'll just salvage later. Yeah, you probably can salvage. But the problem is some people you can't. They will have distant metastases. And ctDNA alone right now off trial cannot be the only decider for you to omit adjuvant therapy. Thank you for your attention. Do we want to take questions later, maybe after all the talks? Would that work, or you want to take it now?
Yes, that's perfect. I don't see any questions in the chat, so I think we'll move on with Dr. Hannah. And audience, if you have questions, just put them in the chat, and we'll try to address them at the end of each presenter's talk.
Great. Thanks so much, Nancy, and thank you to the organizers for having me speak. I want to sort of pivot a little bit, and we all tried to cover a little bit of a different angle, both in our respective specialties. So I'm a medical oncologist, so my sort of lens will be a little bit different than my surgical and radiation colleagues. But I'm happy to talk about some of the clinical applications and integration of ctDNA into your practice as head and neck surgeons. So these are my disclosures. I will highlight that I do get in-kind research support from several of the companies that produce the assays that I'm going to talk about because they're commercially right now available to you to order. And that's Naveris as well as Adela. And I do serve in a consulting and advisory role to them. I'm not endorsing any of these assays. I'm just here to educate you on what we know about them so far. And then you can decide what makes the most sense for your patients. So I put this slide in intentionally, largely because this is a surgical audience and I'm a medical oncologist, but it's really important to recognize that ctDNA is essentially integrated into many solid tumors, and many of you may not know that it's FDA approved as a choice test in many cases. For example, in urothelial cancer now for making adjuvant treatment decisions, as well as in colon cancer. So we actually make treatment decisions based on the presence of ctDNA after surgery and chemoradiation in other cancer types. So for us in medical oncology, it was natural to bring these tools to head and neck oncology, but for many reasons, we're often a smaller community that takes a little more time to adapt these kinds of approaches. But this is not new, is what I would say to you. And I just want you to step outside of your ENT head and neck surgical world and recognize that when we're talking about the applicability of these tools across cancer. And this is a really nice meta-analysis that shows you that essentially, if you have detectable ctDNA across many solid tumors after you finish definitive therapy, that's bad. Patients, that means that there's some sort of residual disease that's you may or may not be detecting that imposes poor outcomes. So that's a good starting point for thinking about why this is important in head and neck cancer. So Nancy nicely went through how we can use these tools in head and neck, specifically in the EBV nasopharynx space, so I won't cover that. But I do want to talk about two disease areas of interest. As we alluded, viral-mediated cancer, specifically HPV-directed oropharynx cancers, but then all of our other cancer types in head and neck, so the so-called HPV agnostic or subtype agnostic ctDNA testing. And there's a lot of different technologies. Some of them are specific to detecting viral sequences in the case of HPV, but then in the non-HPV or viral-directed, we're looking at gene sequences within tumors that are generally specific to the tumor, or methylation signatures or unique flagging of the genome that's unique to cancer that's separate from what you would expect to see in the blood. And that doesn't always need a tumor. That can be what we call tumor naive or uninformed. And those types of tools are very different and have different sensitivities and different pros and cons. So today I'd like to focus a little bit, as I said, on what is clinically available in clinic or available to you to potentially order. And we can talk about this in the discussion about sort of coverage applicability and how these assays are reimbursed. But the story really starts with one assay where there's a large amount of research, not necessarily to say that it's the best, but it's one that's been around since 2020 as a commercially and CLIA certified tool, one that you can actually order in clinic. And this is the tumor tissue modified HPV DNA assay that's a ddPCR. So it's really picking up specific subsequences within the DNA through a PCR method. It's not a whole genome or exomic method. And it's really trying to understand if there are shedded fragments of DNA that relate to HPV sequences from a particular tumor. And it tests for the 5 high-risk subtypes of HPV. And this comes from the NavDX, or it's called NavDX from the Naveris sponsor, but we'll just call it TTMV HPV DNA. So we really wanted to first start to understand when you get this test at baseline, can it give you any useful information? And this is work from one of your colleagues and a tremendous partner of mine in research, Eleni Redig, and our group showing couple of important points. And this was, by the way, this is a prospective collection. This is not retrospective data. This was part of a prospective surveillance trial with this assay. And what we showed was that if you have higher nodal burden and tumor volume, you were more likely to be both detectable at any cutoff, but also have higher values. So more nodal involvement means more likely that you're going to detect this at baseline and shed, and that you're actually going to have a higher value, that higher nodes yield higher values. But importantly, and Nancy highlighted this, it's not perfect. And 10 to 15% of the time, patients, even at baseline with a visible HPV tumor, will be undetectable. And so why is that? And this is a very important slide that I borrow from Eleni. There's a few reasons. One is that sometimes tumors are small and nodal volume and tumor volume is not shedding, like Nancy showed us with one of those small recurrences in the neck in her RT trial. The ctDNA tool is not good enough necessarily to pick up at a sensitivity level that volume of disease. Another possibility is molecular uniqueness or biology, right? There could be integration of the DNA sequence such that, remember, that probe is looking for specific HPV DNA. You just may not be detecting it because that tumor is behaving with a different signature. And that could mean worse biology. We don't know. And lastly, this sort of all ties into sensitivity, right? How well you can detect very low levels of both DNA at particular probe sequences and how much coverage of a particular genome sequence you have. So none of these assays are likely to be perfect, but there's ways to get improved sensitivity, but that comes with a lot of different things in terms of cost, resources, and others. So that being said, I think it's important to realize that we know that testing at baseline for this assay, the NavDX assay, is probably useful to understand and pair with your clinical diagnostics because it gives you some information potentially, as you'll see in the surveillance setting, especially if it's detectable at baseline, and we'll come back to that. Now, what about on treatment? Now, this is a really important red flag caveat. I'm going to show you some results from an early study that we presented at ASCO. This is investigational use. This use of the assay is now trying to understand, as we heard from Nancy and others, could you somehow integrate it into your clinical decision-making for intermediate risk HPV patients getting chemoradiation and make a decision with it in parallel? And so this is our REACT 1.0 study, which basically took high-risk patients that you probably wouldn't want to otherwise de-escalate, like T4s and smokers. And we said, maybe we can add the assay behavior during treatment to understand if you could make a change. And so if patients were detectable at baseline, at a certain cutoff and cleared their DNA mid-treatment, we figured that that was, based on the Chera data, a good starting point, and we would modestly de-escalate. The long and short of it is it looked pretty good, as I'll show you, but we learned some really important things about how the NavDX performs during treatment. So looking at the scores, you can see that pre-treatment scores were interesting and tended to track potentially with patients' risk, their T4 status, their tumor burden. But we also learned a lot about clearance. You can see in the middle bars that regardless of clinical risk, most patients were pretty much clear by the end of treatment. There was only like 0 to 2% of hundreds of patients, of 130 or so patients, who didn't clear. So that's really important. The vast majority of patients, even with intermediate risk disease, did seem to clear by that sort of 95% cutoff of their baseline. That being said, what we found and we thought was compelling as a starting point was that if you looked at the highest risk patients who were de-escalated based on their HPV clearance, they did okay. You know, it's not perfect, but for a 2-year PFS around 90-91% for T4 smokers, given the historical data, the NavDX seemed to help us sort of say that we could maybe de-escalate gently in that population. So again, this is just a starting point for how we might pair it with clinical data to understand how to modestly de-escalate. And of course, Nancy and others are going to keep doing this work with this assay and others. But again, this remains investigational. Changing decisions or omitting therapies is still something we're trying to figure out. But it doesn't mean you shouldn't test at baseline and follow the test to clearance. So this is where the test has the most power, which is the surveillance setting. And the most data actually exists here, both retrospective and prospective. This was Sphere 1. This was the prospective study I alluded to that enrolled patients after consent to follow their HPV DNA and said that if they were detectable and cleared, that was good, and that if they were newly detectable in surveillance, we would trigger both repeat testing to ensure that it was still positive, but also trigger early imaging, in this case, a PET scan. And the idea was to understand if we wanted to understand just the number of recurrences that were identified and triggered by the test first before imaging or symptoms arose. And the long and short of it is, and this is an important table to understand, that the sensitivity performed largely how we expected. Now, you may look at the yellow box and say, wait a minute, that's only 73% sensitive for detecting recurrence. But there's some really important things that you need to look at in the table. The first is look at the low number of events. Any small change in number, one patient changes that percentage dramatically because it's a HPV trial. There were only 4 patients, right, in the lower left box who had a negative HPV DNA with disease evident. And that's that sort of low sensitivity issue that Nancy mentioned. But if you change that number by 1, that sensitivity goes up quite a bit. And you can importantly look at the subscript and know that 2 of those patients out of the 4, we never knew that their baseline was detectable. So that's probably one of the take-home points. For NavDX, if you're detectable at baseline and you clear and you're newly positive, red flags. Those patients have a very high rate of having residual disease. The positive predictive value of that, of a newly positive test when you know they were positive and had cleared at treatment, is very high, 99% in long-term follow-up. And the sensitivity for patients with HPV-16 disease who were detectable at baseline is 91%. That's pretty good. It's not perfect, but it's pretty good. So again, I highlight this because you can jump quickly and say 73% is not good. We don't want to make decisions based on that. And that's a fair point. But you got to look at the table carefully and you got to ask yourself where you're using the test. This is in surveillance. This is not making a decision about treatment based on that sensitivity. It's understanding the likelihood that the test is telling you something about relapse. Okay, that's really important. So how do I use this in clinic? Well, this is one of my patients with a large HPV cancer, and we got imaging after treatment, and unfortunately you can see some small lung nodules, but they were too small to biopsy. And so I, as you can see in the number 1 where the scan was done and their HPV DNA trend, their DNA was rising. This is a patient who was positive, cleared all the way down to undetectable after treatment, has a newly rising value and suspicious lung nodules. This is a patient with cancer. And you could say to me, Glenn, the standard is to monitor this patient until they are biopsy proven. How do you know that starting treatment early is going to make a difference? You're absolutely right. But when I had an informed discussion with the patient, they were willing to start immunotherapy, which is our first line salvage therapy for this recurrent metastatic scenario. And in this case, this is very analogous to a rising PSA after prostate cancer therapy. It's biochemical recurrence. And look what happens. We started immunotherapy and the patient cleared. If I had waited for detectable large disease burden, would that have happened? I don't know. But let me tell you, if this was me, I'd want to be starting some sort of therapy earlier. Now, we need trials to answer this question, but I'll tell you, they take a long time. These scenarios are not going to come every single day to run a big phase 3 trial. These are unfortunately, sadly, but also in a good way, these are infrequent events that the medical oncologist often deals with. But this is the reality we're faced with in clinic right now, is what to do with these patients. And I'm of the school of thought that we need to do studies to understand earlier start of these therapies, to understand how they improve outcomes. But this is someone I would feel comfortable offering in an informed discussion early systemic therapy too. Now, what about in the recurrent metastatic setting? Now, remember, that's my role. Often the surgeon and often the radiation oncologist have exhausted many of their offerings, except for palliation. But we needed to understand, does this NavDX work in that setting? And the short answer is it does. I use it serially in addition to scans in these patients. It's interesting, there's a modest correlation between values and disease burden, but what's really interesting is that it changes its behavior based on the modality of therapy. So someone on immunotherapy may have more of a sort of undulating or up and down ctDNA in the metastatic setting, maybe because of immunosurveillance, the way the drug is working. But someone who gets ablative radiation palliatively or ablative chemo, it tanks quickly. And that's based on how we think that the assay or sorry, the tumor is behaving in that disease setting. So we're still learning a lot about this. But what's interesting is we published that if you can get someone to negative status in the metastatic setting to undetectable, they do better. That makes sense, right? If you can clear them to an undetectable ctDNA burden and their scans are clear, they're likely going to live longer even with metastatic disease. So how do I apply this in clinic? This is again one of my HPV patients who has metastatic disease. He was already on Pembro. I met him because he transferred from another oncologist and I started tracking his ctDNA. Look at it. His scans, his CT scans, kept saying, no disease, no disease, complete response on Pembro. Nope, look at that ctDNA, it's rising. And finally, when it had doubled, I got a PET. And the PET showed a hot subcarinal node. And then I sent the patient to Ray Mack and I said, do some fancy MR-Linac radiation and knock that node out. And he did, and look what happened. He cleared. And you see a little blip there on the indeterminate level, but he's remained negative. So I'm going to argue with you that if I had left him alone, he would have never been tested. One day his scan would have blown up with disease, and maybe he wouldn't have lived as long as he's living now. He's now 5 years in with metastatic disease. That's hard for me to prove to you, but I'm pretty sure it's the case. That getting him to MRD negative, and that's an important term, minimal residual disease negative, on that assay with negative scans, in my opinion, and in other cancers, is very valuable in the metastatic setting, not just in the definitive setting. Okay, so that's what we know today about HPV DNA. Dan is doing some fantastic work with his new NGS platform, DeepSeek, but what I chose to share with you was what we have in terms of clinical availability, which you can pull up an order form and actually send. We can talk about reimbursement in the Q&A. What about non-HPV cancers? Well, there are a lot of assays out there, and I'm just showing you some of the companies at the bottom, and there are pros and cons to them. There are Tumor Inform that rely on the cancer. They biopsy it, they make a personalized assay, and they follow mutations in the blood. And there are Tumor Naive, as I said, that use methylation patterns. They all have pros and cons, and there's lots of different companies. So people say to me, Glenn, which one do you use? Frankly, I don't think that many of them are all that different than each other, and we can debate that. Many of them are just competing for the same sort of space of getting into the oncology space, but all have very similar constructs and how they work. I highlight two. Natera's assay is Signatera, and Adela is the newly launched assay out of Princess Margaret called GuidePoint. The reason I highlight these is because these are now clinically available. You can actually order these in your clinic. The rest of these are not reimbursed. They're not easily ordered and are still very much investigational. So what's the data? It's very sparse. This is sort of the end. We do know, and this is from the Belgium group, this is not Signatera, but this is a 24 gene in-house panel that looks at just blood, so tumor naive. And they showed, not surprisingly, that if you treat patients with chemoradiation and you finish treatment and patients are positive for ctDNA afterwards, they do worse. Look at the 2-year PFS. It's horrible, right? It's 4 times worse for the patients who have positives MRD. But it's interesting because now this is HPV agnostic and it doesn't require a biopsy, which is sometimes difficult. Now going forward, this is the Scott Bratman Lab sort of Princess Margaret assay that's now been rolled into a company called Adela, and they're now launching an early access program with their tool GuidePoint, which is again tumor naive. You don't need a biopsy, showing very similar findings, right? Look at this. It's a methylation assay, same story. Good sensitivity. And if you have positivity after treatment in this pilot cohort, you did much, much worse. Terrible hazard ratio, right? 35. So all kind of saying the same thing. And to round it all out, we did something similar. We had availability of the tumor-informed assay by Natera called Signatera. So this requires a biopsy, as Nancy was alluding. You create a personalized sequencing platform against that biopsy, and then you're tracking those cancer mutations in the blood. And this has, again, very similar story in a pilot cohort of head and neck patients, mostly mucosal squam. It had pretty good sensitivity in the low 90s. And same story, if you were positive after treatment, whether it was surgery or chemoradiation, you did much worse. Now, importantly, we didn't say anything about changing therapy. We just said that a positive test after treatment was a bad sign. And now it's on us to do studies to say, well, wait a minute, if you're positive after treatment, maybe we should intensify your therapy. Or if you're negative after treatment, maybe we should explore de-intensification. And that's where the trials are. But please don't confuse that with the fact that these tests are useless right now. They are not. They are quite informative in line with your clinical data, your exam, your imaging. They can help you, as Nancy alluded, with an equivocal PET scan. If you have a new positive, don't sit on that for 3 months. Follow that closely, for example. So my final slide is kind of where we are with these available tools. I think you need an individualized approach with your patients, but I'm going to tell you a little secret. We actually did a study of surveying the patients on our prospective trial about their feelings about the test, its positivity, and the unknowns. Overwhelmingly, your patients want these tests. They're not scared about false positives. They're not scared about trending DNA positives. You're scared because you don't know what to do with it. But don't confuse that with the patient. The patients know that this is an important tool evolving in cancer medicine, and they want to know, one way or another. So learn with them, get the tools, explain to them the pros and cons. It's not perfect, but as long as they understand what the test is being used for, they're happy to participate. It's very helpful to follow when detected at baseline and prior to treatments, particularly if it clears and it's newly positive. It's very useful in determining occult disease status. If a patient is newly positive, you need to hunt for and find the cancer. You should do a good search. This is my opinion in bullet 3. I am confused why these tests are not at least mentioned in a subscript in the NCCN. Again, there's no need for them to be marked as sort of, required or strongly recommended, but I think there is overwhelming data for these tools as an aggregate that there should at least be mention of, hey, have a discussion with your patient about whether or not it's appropriate to track ctDNA. The future is in the last two. Therapeutic and surveillance impact of screening and early detection. Nancy covered this. We don't know if detecting these tests years before someone shows up to clinic is going to improve the chance that they have good outcomes. Hopefully, tools like Dan's assay will help us answer that. What does MRD positivity, what can we do with that, and should we start treatment earlier? Well, that's something I'm going to try to work on. And can it be a useful biomarker on treatment to make decisions? And you can see from Nancy's work and mine and Dan and others, we're trying to figure out, can we use this in real time after radiation or during chemoradiation or after surgery to start modifying therapy? Not today outside of a trial, but hopefully in the years to come. And what I kind of see is maybe a risk score. Maybe one day you'll see us, this is kind of my vision of the future. I'll say, you come in, you get your scan, an AI robot reads your scan better than your radiologist and says, does this cool readout, checks your blood, knows your DNA profile, knows your ctDNA, knows your methylation signature, knows your clinical status, and says, you have a 26.6% chance of recurrence and you need this therapy. That's not crazy, guys. What is the 10-year cardiovascular risk assessment tool for when you should take a statin or not? Cardiology has it figured out. We're going to get there. We just have to combine all these tools going forward, and hopefully that's what's going to happen in the years to come. Thanks.
Awesome. Thanks so much, Dr. Hanna. We've got a couple questions in the chat. One is that um, a rising tumor TTMV HPV DNA after clearance has a 99% positive predictive value. So clinically, when NavDx turns positive, but the imaging is still negative, do you believe that should change management today? And what level of evidence would you need before recommending early treatment rather than waiting?
So there's an opinion and there's a trial answer, or, a general answer. The opinion I have is that if someone, as I've said to you, is newly detectable, I will have a conversation with the patient, an informed discussion about the pros and cons of a choice, but I will consider in the appropriate setting discussing therapy with that patient, and I've had good success with that. That said, I prefer a clinical trial. And to answer the question, we do have trials that are open. One, we will have, so there's a few iterations sort of brewing, but I know of at least two studies where it will take patients who are ctDNA detectable after definitive therapy and randomize them or allocate them to early immunotherapy or early chemoimmunotherapy to clear the ctDNA. So those trials are starting up now. What I will say to you is please refer patients for those. That's actually, it sounds like it's a common event. It's actually not that common, just across the cancer world. Finding those patients who have no gross disease, who are ctDNA positive, is a gem. And you want to send them for trials so we learn how to treat them. Because a lot of times you'll get the ctDNA and then you'll get a scan and there's a finding. They've got a MET or they've got this. So that's a different scenario. Really, what we're interested in is just those biochemically positive patients. But I would argue that there is at least a discussion to be had about early treatment in those patients.
Perfect. Thank you. I think there was a very similar question in regards to EBV, and so I think that probably answers that question as well. And so we'll move on to Dr. Faden's talk.
I'm sorry, I did this backwards. Okay. So thank you so much for having me. It's a pleasure to be here to be the third speaker. Hopefully we still have everyone's attention. I know it's getting late in the evening. Here are my disclosures. Just rearrange some things on my screen. I apologize. So I'm going to focus on the application of ctDNA in patients treated with surgery. And in particular, we're going to focus both on monitoring or surveillance of patients after surgery, but also on minimal residual disease detection, or MRD. This is the time point right after surgery. And to sort of prime this discussion, I want to talk a bit about an important concept, which is tumor burden, or in the liquid biopsy world, what we call tumor fraction, which is the amount of total cell-free DNA that comes from tumor cells, so ctDNA. And the reason this is important is because the performance metrics of liquid biopsies really depend on the tumor fraction and thus the clinical context in which they're being applied. So for example, when you use a liquid biopsy at the time of diagnosis with high tumor burden or at clinical relapse, you have very high performance. When you utilize these same approaches in settings with low tumor fraction, in particular MRD, which is really the best example of an ultra low tumor burden setting, you have much different performance, lower performance, lower sensitivity, and really you need much more sensitive assays. And this is going to be sort of a theme we're going to talk about in this talk. So what do we know about the use? What do we know about the use of ctDNA in HPV-associated head and neck cancer in patients treated with surgery? So what I'm showing you here are two different studies. One is from our group on the top. One is from the Mayo group on the bottom. We're first looking at surveillance, the use of HPV DNA for surveillance in patients treated with surgery. And what you can see is that really there's excellent performance metrics, as you saw in some of the earlier talks, in the surveillance setting for patients treated with surgery using cT-HPV DNA. You see these very wide Kaplan-Meier curves, as Glenn refers to them as gator mouth curves. What about in the MRD setting, so right after surgery? Well, there we see, less robust performance. These are the same patients. Now we're looking at MRD time points. The Kaplan-Meier curves look very different. And I think this can really is best sort of highlighted by looking at patients who are at the highest risk of recurrence. This is something that Nancy and Glenn and I noted in a recent editorial that accompanied this paper on the bottom, which was from David Routman. When you look, for example, at patients who are at high risk for recurrence, so these are patients with advanced nodal stage disease treated with de-escalated therapy, in this case, DART, the 24-month PFS in cT-HPV-DNA negative patients was only 63%. So really not great performance metrics, and really argues for the need for more sensitive assays, specifically for MRD testing. This point is really hit home by the trial that you already heard about out of MSK that Nancy mentioned. The PATH study, and I'm just going to very briefly re-mention it, which is that essentially patients treated with surgery who had 2 negative cT-HPV-DNA levels in the MRD setting could go on to observation rather than adjuvant treatment. And in this study, 33% of patients had false negative MRD testing, which led to closure of that trial arm. And then notably, 45% of patients failed screening to go onto the trial because of lower undetectable levels of cT-HPV DNA. So this really argues for the need for more sensitive assays. This is a study that we ran using a more sensitive approach that uses HPV whole genome sequencing. This is called the CLEAR HPV Cancer Study. This was presented at ASCO last year. This was a prospective observational cohort study in 103 patients. It's now available as a preprint. It hopefully will be out very soon as a publication. What we see in this trial, again, first looking at surveillance, so not at MRD, but at surveillance, we see very high performance metrics, again, of cT-HPV DNA. If you look at 2-year DFS and OS, 100% DFS for cT-HPV DNA negative versus 0% for positive. Similar findings for OS. Here now looking at MRD, we see slightly different findings. With a more sensitive assay, we see significantly better performance for MRD detection. Again, DFS 100% at 24 months for cT-HPV negative, 60%, excuse me, for cT-HPV positive. Similar findings for overall survival. Now, this trial was actually done across all HPV-associated head and neck cancers, not just oropharynx. But when you subset the analysis into oropharynx only, and also by different stages, so early stage versus late stage, all of these findings hold. In this particular study, we actually looked specifically at multiple different approaches for detecting MRD, both available platforms and whole genome sequencing-based platforms. And you can see that the increased sensitivity really matters. Detection of MRD went from 33% to 83%, so more than doubling in your sensitivity of MRD detection. And this directly translates to longer lead times for molecular detection to clinical detection of recurrence, from 4 months with currently available approaches to 7 months with whole genome sequencing-based approaches. So the question of utilizing MRD status as a risk stratifier is being looked at by many different groups and interventional trials. This is just one of a number of different trials. I happen to particularly like this trial, and I'll explain why, but this is from James Bates at Emory. This is essentially taking intermediate risk patients who are treated with TORS and then using cT-HPV DNA to risk stratify patients into either standard adjuvant dosing per ECOG 3311 if they're ctDNA positive, or lower dose radiation, 36 gray, if they're cT-HPV DNA negative. This study, the interim results were presented at ASCO last year. I believe we're going to get updated results at the multidisciplinary head and neck cancer meeting in about a month. But the reason I really like this trial is because I think it really plays to the strengths of where ctDNA and cT-HPV DNA are right now, which is that we know there's very high specificity. So if you're positive after surgery, you have a very high likelihood of having residual disease. You need adjuvant radiation. If you're negative, well, I just showed you we can't quite say with 100% assurance that you don't have any residual disease, but we probably can say that the residual disease you do have, if you have any, is truly, truly microscopic. And that can likely be cleaned up with very low dose radiation, which potentially should save some morbidity, although that also needs to be studied. So I'm going to move on to talk about HPV independent head and neck cancer now. And for this discussion, I'm going to introduce a concept that I think is really important for understanding the slides, which is how we measure sensitivity of assays. These are specifically for NGS-based assays, and that's something called parts per million, or ppm, which is the number of ctDNA fragments you can detect out of a million cell-free DNA molecules. And what I'm showing you here are a number of different commercially available assays. You're probably familiar with a number of these. In red are tumor agnostic assays, meaning they don't need a biopsy. In black are tumor informed assays, and they're ranked by their limits of detection in parts per million. You heard a bunch already about the Natera Signatera assay, which is the most commonly ordered tumor informed assay across cancer types. In the bars are the number of targets in the assay that are custom to the individual's tumor. And you can basically see that Natera, Signatera, comes in at about 100 parts per million is the LOD. And below you can see a number of assays that are now coming to market or already at market, in which the limits of detection are getting lower and lower, now getting below 1 part per million. All of these assays you see here are either already clinically available or will be available in 2026. And this asterisk here is meant to show you that actually out of all these assays, this is the only assay that actually has CMS reimbursement approval specifically for head and neck cancer. Although, again, as Glenn mentioned, we can talk more about reimbursement for these assays, but I think that's important to mention. This approval just came very recently, and I think the RaDaR assay is still in soft launch, but will be available in 2026. So how do these assays perform for detecting residual disease and in the surveillance setting after surgery? This is an HPV-independent head and neck cancer. Here's a study that we have available as a preprint. I believe it's coming out early next week, actually, looking at the use of one of these tumor-informed assays. It happens to be an assay called Prednisone Beacon, which looks at 50 tumor-informed targets. First, looking again at the surveillance setting, you see again very high discrimination between ctHPV positive and negative in the KM curves. However, if you look again at the performance specifically in the MRD setting, so right after surgery, significantly less robust. In this study, sensitivity for MRD detection was only 55%, so not super great. Paralleling the story I was telling in HPV positive head and neck cancers, here I'm showing you results from a study that we published using a significantly more sensitive human whole genome sequencing based assay that's called Maestro. This is coming to market currently, being commercialized by Exact Sciences, will be called OncoDetect. Again, this is a human whole genome sequencing based assay that can target up to 5,000 tumor-informed variants. Here, looking at the performance for MRD, a better discrimination. Here, looking at the sensitivity, significantly higher sensitivity. When you compare this to the sensitivity of the HPV whole genome sequencing assay that I showed you previously, you see those levels are pretty similar. And in fact, if you look at the parts per million of those two assays, they're relatively similar, which all trends. Lastly, I think this slide really drives home the point I'm trying to make in this talk, which is that in the MRD setting, sensitivity really matters. What I'm showing you here are data points from the same study I just showed you using that Maestro assay, human whole genome sequencing based approach. On the y-axis is the tumor fraction or the in parts per million of the blood samples in the MRD setting. And on the x-axis are days from surgery. Many of these patients, you can see we were doing serial sampling because this was on a clinical trial. But the point is that if you look at the levels of at ppm of these different samples in the MRD setting, you see they're quite low. They're around 1, 10, under 100. And the point is that if you're using an assay that has an already limit of detection that's above these levels, these are automatically all going to be false negatives. So the point kind of is that the sensitivity of these assays actually in the surveillance setting probably is not quite as important, but in the MRD setting really matters. These would all be false negatives with assays that were up in this range. So we know that ctDNA performs quite well for surveillance after surgery, and that there's some room for improvement still in the MRD setting. And so I think what we really need now are more prospective studies looking at the performance of newer assays that are more sensitive with lower ppm LODs to better understand how these approaches will work in the MRD setting. There's many of these studies going on. This is just one of them that we're running at our site using a different assay that we've talked about so far called Haystack MRD. But I think there's a number of these trials happening, and I think this is really going to be informative over the next few years to better understand how these more sensitive assays will perform specifically in MRD. So to summarize, how should we use ctDNA, ctHPV DNA after surgery in 2026? So in the surveillance setting, similar to CRT, and in the recurrent metastatic setting, these approaches have very high sensitivity, specificity, positive and negative predictive value. And the lead times are superior to clinical detection of recurrence, typically on average about 3 to 4 months lead time. With these more sensitive assays that we're discussing, specifically with whole genome sequencing, these lead times are typically on average in the range of 6 to 8 months, although they can certainly be longer. In the MRD setting, current assays that are at market really don't have high enough sensitivity for absolute MRD detection. The studies I showed you on average are looking at about less than 60% sensitivity in the MRD setting. However, newer approaches, both for HPV positive, HPV independent, using whole genome sequencing, are pushing these levels higher, sensitivity levels higher, on average over 80%, although still imperfect. We do know, though, that the specificity is very high after a washout period, which really depends on the sensitivity of the assay that you're using, somewhere between 1 and 7 days, and that a positive test is high specificity for residual disease. So I think the take-home message here really is that it's very critical to consider the clinical context in which you're using these approaches and the specific assay sensitivity when you're thinking about MRD, when you're interpreting results for clinical decision-making. Thank you.
Excellent. Thank you all so much. There were a couple of questions in the chat, which I think have been answered. And it's now about 10 past the hour, so we will plan to adjourn unless there are any further questions. Again, thank you, everyone. Thank you to the attendees, to our panelists, and to our administrators. Thank you very much. Appreciate it.